Do breast implants cause cancer?
Yes, they do. Yeah, so not all breast implants, but the work we've done around this blood cancer, this breast implant-associated anaplastic large cell lymphoma, BIALCL, is directly attributed to textured implants and more particularly a high risk with the really rough textured implants.
Is that true? Can the nipple die and fall off?
Yeah, so it is a risk, and absolutely not just the blood supply of the nipple but the nerve supply of the nipple as well. So not uncommon immediately after surgery with a swelling that you lose feeling, but you would hope that most of the sensitivity of the nipple comes back.
This program's content is provided solely for informational purposes and should not be construed as medical, legal, or financial advice. Views expressed are opinions only. Our discussions are general and not focused on specific companies or individuals unless explicitly mentioned. We strongly recommend consulting a qualified medical professional before contemplating any major or minor medical procedures. Be advised that some content discussed may be distressing. Discretion is advised. The hosts of this program believe all people should be able to access cosmetic surgery procedures free from judgment. Welcome to Surgery Secrets, Beauty's Dark Side. I'm Madison Johnstone and I'm co-hosting this with Michael Fraser. This podcast explores the dark themes of the cosmetic surgery industry worldwide, with Season 1 focusing on Australia. Make sure you follow us on Instagram and TikTok at operation.redress for snippets and shorts from today's episode. If you have breast implants or are considering getting breast implants, this episode is an extremely important listen. With the amount of marketing which shows that breast implants are low risk or pain-free, and then when you couple this with the glamourization and sexualization of breast implants currently on Instagram and TikTok, it unfortunately leaves patients uninformed. This episode is not intended to fearmonger. Instead, it intends to balance out all of this advertising. Today, we are lucky enough to have Professor Anand Deva, who will be sharing his insights on breast implants. Professor Anand Deva uses his platform to raise awareness around the risks of breast implants as well as potential links to cancer. He is a specialist plastic surgeon who has established a clinic called the MQ Health Integrated Breast Implant Check Clinic. Would you like to share more about your qualifications and experience?
Thanks. It's lovely to join you today. Look, I've been in practice now for close to 24 years. So I'm a plastic surgeon through a very long and tedious process of training and through the College of Surgeons. I've head the department now at Macquarie University. And in the last 9 or 10 years, I've actually looked at integrating health as well. So I do work closely with New South Wales Health and a few of the local health districts to set up affordable, accessible and efficient models of healthcare. One of which, of course, you've mentioned is the Implant Check Clinic.
You could be making a fortune riding the breast implant wave. Like, why are you on a different path? What's driving you?
Well, look, it started off actually whilst I was training. Interesting story. So my first encounter with a breast implant complication was a patient. She was presenting for her third revision operation. So she'd had 2 previous episodes where the implants became hard, and I was still training at the time, and she was on the list with one of my mentors. And it was I spoke to the patient, and she was presenting for another operation, and I turned to my mentor and said, look, why do these implants keep getting hard? And he actually said, I've got no idea. It's called capsular contracture. And so I'd just come out of doing some laboratory research on infection and contamination of instruments and devices. And so a little niggle at the back of my head said, oh, maybe we should try and find out what's going on. Why do women's implants become hard? So I rang the lab that I was working in. I convinced the patient to give consent to get some of the tissue and the implant across to the laboratory, and actually drove the specimens to the lab that evening. And lo and behold, when we looked under the microscope and we cultured some of the tissue around the implant, they were full of bacteria. So that then led to a long quest to uncover the science behind capsular contracture. So that was kind of my first sort of academic or research interest. It turns out actually that low-level contamination of implants causes inflammation, and the inflammation eventually causes like a scar tissue, and then ultimately causes pain, deformity, and can actually rupture the implant. Once we made that link, it became clear to me that we should try and prevent it, because that would be of ultimate benefit to patients, so people don't have revision surgery and obviously suffer with pain and deformity. So to cut a long story short, most of my career has been about complications related to breast implants, how we can find out what causes them, but more importantly, how we can translate that into better practice to give women a better, sustainable, more long-lasting result.
For those of our viewers and listeners who are watching today and who are just starting their research journey into breast implants, so that we can really get into understand what is going wrong with breast implants, how they rupture, can you tell us what exactly a breast implant is?
So the first breast implant was put in 1962. It was a bit of a whim, right? So there were these two surgeons in Texas that were playing around with a bag of blood, and for whatever reason they thought it might be a good idea to put that into a breast and augment a breast for cosmetic surgery. And so out of that was born the Dow Corning implant that for a long time was used purely for cosmetic surgery, and then to some extent spread to reconstruction as well for women who had breast cancer and needed volume replaced. But it's an old device. That technology has changed somewhat, but the concept of having an outer shell and an inner sort of jelly liquid has gone through many iterations. Soon after they got onto the market, capsular contracture was discovered. In fact, the first patient who had implants became hard and ultimately had to have them removed. And so there's this sort of kind of commercially driven product, elective surgery. Yes, there is some reconstruction, but it became very quickly linked to adverse events. In the 90s, there was some research that linked breast implants to autoimmune disease, so things like rheumatoid arthritis and things where the immune system sort of attacks your own body. That led in the US to a ban on silicone for some time, so the regulator stepped in. But then over time, there's been these cycles of complications, sadly people having to have more surgery, potentially suffering as a result of that, then leading to regulatory action. That cycle I've witnessed in my own career many times. So there was after that the PIP implant crisis, where a manufacturer in France was actually using non-medical grade silicone for implants, which resulted in a tremendous harm and rupture of these implants. That led to a whole series of regulatory actions, actually gave birth to our Australian breast device registry as a result of that. And of course, the latest crisis has been around a cancer, a type of rare blood cancer, a lymphoma, that's been related to textured breast implants, and I've been involved in some of the research on that. So that fateful day when I looked at this poor patient who's presenting for more surgery, and my curiosity as to what might be causing capsular contractures led to a whole career looking at the safety of these devices. And what we've learned is that they're not inert devices, that there is some response of the body to this device going in. And then I think we're trying to untangle then what happens afterwards. So the inflammation leading to contracture was something we discovered very, very early on. Inflammation leading to potentially this lymphoma is something that we worked on over the last 10 years. And now we're looking at inflammation as a potential driver for a whole heap of other symptoms as well. So it's a legacy device. I think there is so much that we know about these devices in terms of risk and adverse events that it surprises me that that sort of information is not given to patients when they first seek elective cosmetic surgery in particular.
One of the things that we say is you don't know what you don't know. So patients, they don't know what to ask because they're not as educated as their doctor. So should there be a more standardized approach to consults where doctors give the same information, they know exactly what they're supposed to give, so patients aren't left guessing about what they should be asking?
Absolutely. I think the patient here shouldn't be seen as a commodity, right? I mean, I think every patient who's thinking about implants, there's a myriad of things that might drive them to think about it in the first place. But then it's not our job to sell the product or sell the procedure. It's our job to inform them and to educate them and to make sure that the decision they make to proceed with surgery is one that they make. It's not that we're trying to push them to make. And so there is this, I think, real uncomfortable struggle between a commercial driver and a health driver. And I think it comes to a very sharp point, particularly in cosmetic surgery and more particularly around breast augmentation surgery.
You mentioned the safety of implants. Is there somewhere where patients can check a register or where they can check the safety of their implants that they plan to get?
I've been working particularly with New South Wales Health on a patient resource and a doctor resource actually. It's available. It's a toolkit for the management of breast implants. Most of it is actually about a series of steps that my colleagues I hope will incorporate into their practice. But part of the package is an informed education consent checklist. So I think it's hard to change practice, right? So I think there's many motivations in this space. For me, it's about, I think what you said was quite important. Is there something that we should be doing? And the answer is definitely yes. So then what's the minimum that we should be doing? So that's kind of how we approached it. And I think patients can be overwhelmed with a lot of information, conflicting information. Social media tends to downplay some of these risks. So let me focus on that checklist. But essentially, it starts off by saying breast implants are not lifetime devices, and by choosing to proceed with surgery, you are signing up for more surgery. So I think that's a really good place to start, because a lot of women I see, particularly if things don't go well, are not told that. Oh, the doctor said, that's it, I'm fine, call me if there's a problem. That's not really being honest with patients, knowing what we know about these devices. And that's going to not just cause problems to your health, but also cost you. That's something that people really have to accept. Then there are specific risks associated with the breast implant. So the second part of the checklist involves a list of things written in very plain English, right? Because I think a lot of the information out there is perhaps a little bit too complicated. It doesn't spell out in black and white, you could get this. You could get infection. These implants could cause serious issues to your health. They can change your breast. Your breast can change. You can have chronic pain. So these are things that are very, very simple, but listed in a way that people can understand. The third part of it, I think, so you need to understand and accept those complications. And some of these complications don't occur immediately. You might be fine for a few years, and then 3 or 4 years down the track, they accumulate. The third thing is I think every breast implant should be registered. So Australia has led in this. The breast device registry is capturing pretty much all the implants that are going into Australian women in Australia. Now we can talk about implants going in overseas. That's another story. But at least now there is a repository of information that captures these devices, their serial numbers, the manufacturer, so that going forward, when things go wrong, we can go back and check, it's this particular device or this particular surgeon that might have put it in. And the fourth part of it, I think, is that if an implant goes in today, there needs to be lifelong surveillance. So I've been pushing for this all my career. In my practice, if I'm putting an implant in for either cosmetic surgery, reconstruction, or revising an implant, that patient is wedded to me for life, right, whether they like it or not. And I think the simple act of saying to a patient, look, come back every year, I'll check the implant, I'll check your breast. After 40, women have a risk of breast cancer as well. So if you can incorporate screening for breast cancer and checking their implants, you're doing them a service, right? And then, of course, as a surgeon putting the implant, you need to take responsibility for some of the downstream problems. And I found that over time, it serves two purposes. One is that it gives me a lot of data on my own practice. So you know what works and what doesn't work. And you can be quite honest with patients. If they have unreasonable expectations, you say, look, in my experience, putting this sort of implant in this case is not going to work because I've done it. But I think it also makes you a much more humble surgeon because you see your own results over time, and some of the claims that I see in social media, I just shake my head because they're not true. So, of course, and the final thing, so registering the device, knowing risks, and I think ultimately it's a shared decision. So I think that's part of the fifth and final most important thing, is that it's a decision where you are there to give information transparently, clearly, in language that the patient can understand, and then the process of an informed and educated consent decision is made, but the decision is not mine, it is the patient's. And I think that's, if we did all that, then we wouldn't have to talk today, right? So that's a system that I think would be the ideal. And I've spelt it out in black and white. The challenge, of course, is how do you get that sort of wonderful system in place? And I've spent most of my career trying to argue the facts and the data, publishing around what happens when that doesn't happen. And it's a long, hard process to make that change, particularly when there are so many drivers pulling this industry in many different directions.
How many people, how many women in Australia are getting implants, maybe in percentage or in total? What?
In Australia, we've got a reasonable idea. It's around about 20,000, and about 75% of those are for cosmetic surgery and 25% of them are for reconstruction. Those numbers are continually updated every year by the Breast Device Registry. And over time, those numbers will become really accurate. So it's a wonderful resource, and we should be proud in Australia that, the PIP crisis led to the establishment of the ABDR through federal funding and partnership with Monash University, and it's a great resource. As it grows and matures and the data becomes more solid, I would hope that we'll be able to better capture complications. So if a patient on the ABDR presented for revision surgery, I would think it should be mandatory that data is captured and then fed into the registry, and so we get a better idea of these devices. What we don't have data on is women going overseas who then get implants. And so this is where what you mentioned, the Implant Check Clinic, has given us some really valuable information. So we've just published a paper on the first 600 women that have walked in through our doors, and it's not the same as following up a woman from day one, over decades and seeing the performance of the device and the complications. This is giving us a snapshot of people walking off the street with implants. And the really interesting information, and they're complementary, from the Implant Check Clinic shows that the majority of women are kind of, on average 10 years later, are kind of not overwhelmed by the decision. So, they might have been happy for the first few years, but then things like weight loss, weight gain, pregnancy, menopause, issues related to the device start to eat away at the happiness and, perhaps question the reason for why they had it in the first place. So I think that's really important information because a lot of these patients are not followed up. This data is lost. So, and data is the key here. We can have lots of opinions. People can say this, can say that, but ultimately as an academic, I like to present solid data analysis and then form the policy decisions or the translational research to improve the system. That's always been my approach. And so I think that as we go forward, this data will accrue and ultimately feed into the regulator, will feed into the health profession, but most importantly into the heads of some of my colleagues so that they change their practice accordingly.
You're saying that essentially at the 10-year mark, most of them weren't happy that they got implants? Is that sort of what the data is showing? Or
yeah, so it's not like you would expect that these devices, were universally, changing someone's quality of life, and it was the best decision ever. That would be a sustained thing over time, and we can't look back at the first or second year, but by the time you hit 10 years living with an implant, particularly for cosmetic surgery, the results are pretty neutral. It's like, oh, okay, they're all right. And of course, in some women, a certain percentage of them actually, it's not good. They've had complications or they've had revision surgery, they've had to fork out more money for more surgery, and then it becomes more of a liability. And then they question why they had them in the first place. So it goes back to what we talked about before. If the decision was made by the patient in the beginning and she was fully informed and accepted these risks, if and when they occur, it's a different response to if she was not told or it was a sales job or she was pushed to have the decision. We talk about this concept of a constrained choice, right? So if someone walks in to a practice that is very commercially driven and the aim is to get them to sign up for surgery and they skimp on some of the informed, educated consent process and downplay some of the risks, then when things go wrong and someone was not informed and it wasn't an informed decision, it wasn't her decision, it was a commercially driven decision, then I think the consequences of that particular patient are devastating. They feel shame, they feel guilt, why wasn't I told? They feel anger, and I deal with these patients every day in my practice. I feel sad that that's the consequence of something, and they often blame themselves, which is, I think, even sadder.
Has your data captured what age women are typically getting breast implants?
Look, It's generally speaking, the time they come for their assessment, they're about 10 years down the track. The average age in the clinic is sitting around 40. So you would say in their sort of 20s, late 20s and 30s. There are kind of two peaks here. First is obviously younger women that have, for whatever reason, want to get cosmetic augmentation early. But then there's also another group of women who've had children, who've obviously breastfed and they've lost volume, and that's a second peak, usually like 30s, that also seek augmentation as well.
For those younger women, is there any special consideration that needs to go into giving them breast implants, for example? What age are the breasts fully developed and what are the potential problems with getting them done when you're, say, aged 18 to 24?
Well, it doesn't form my practice, right, honestly. The younger women I see have got some sort of breast deformity, so one side's bigger than the other. I think that's a different population. So these are women essentially have normal breasts who just want bigger breasts. And I think there's a physical maturity issue, so I think 18 is way too young. But, everyone goes through developmental stages slightly differently. But I also think there's a mental maturity as well that you need to take into account. And how much of, the medium to long-term risk do they actually accept and understand? And so it really concerns me if people are putting implants into, essentially teenagers or adolescents that haven't grasped the consequences of that decision. I'm not sure how to get around it, so I think there's always going to be a population that will feed into the demand for that, whatever the drivers are. There's societal, vulnerability, body image, this portrayal of a perfect body. Women are made to feel inadequate, for whatever reason, which I think is wrong. That demand will always be there, and they're particularly vulnerable to advertising, social media, and we've talked about this over many years as well.
Before I noted that you were talking about women that have had children and you said their breasts have lost volume. When looking at the advertising, the way doctors speak about breasts sometimes concerns me because they'll speak in a way that's sort of like, are your boobs saggy? Sort of like negative language to suggest that there's something wrong with you, negative about that. And I've often wondered, why don't they use medical language to describe, and you're not using medical language, but you're using language that doesn't make them sound like there's something wrong with them.
There's nothing wrong with them. I mean, that's what happens after some women breastfeed, and it depends on the starting point and how long you breastfeed for, and there's so many different factors. I think at the end of the day, it's not our job to make value judgments as to what looks good or not. If the patient walks in and it affects them in some way, then we accept that, but then we talk about, what their expectations are and then what the risks are. So our job is to inform, it's not to sell. And so terms that are pejorative or say, your boobs look terrible or they're saggy or whatever, I don't think is helpful. Often these patients come to that judgment themselves for whatever reason. Ultimately, it's about the patient coming to you, wanting information about something they're worried about, that's healthcare, and then us giving good, honest advice and giving them options and informing them of the risks and saying, go away and think about it. And, if you really want it done, come back and let's have a second conversation. If you really want it done, okay, maybe, but, are you sure you understand the risk? So the process is very different.
From our observations, patients try to do a lot of research before they come in and get a procedure. And a lot of that research seems to happen on social media. How well researched do you think they are when they come in?
Oh, it varies. There is a group of patients that are increasingly we're seeing in practice, and these are women who have implants and feel very unwell. They've got a range of systemic symptoms, chronic fatigue, joint pains, anxiety, depression. And I find that those women are very well informed. The problem is that sometimes strong beliefs are formed without the backing of science and evidence. And so it's a difficult position. I mean, my sense is that once again, to talk about the reverse, people are getting implants removed once again and falling prey to commercial forces. saying, don't go anywhere else, I'm the only one who can do this properly. So the rise of the explant expert, for example, we've seen in recent years. And it's kind of sad because that misinformation or commercial driver or whatever it is on social media has led them to get implants in the first place. They regret them and they want them out, and then they've fallen prey to the same system again. People are not going to stop looking at social media and looking at the internet for information. And I welcome that. It's about whether or not when they're in the consult room and they present something they've heard or anecdotal evidence, or my friend said this happened to her, our job, or my job particularly, is to say, well, yeah, I understand that, you've heard that, but this is what the data shows. This is what our publication shows. Here are the findings. Here are the risks, So I think you bring it back down to solid data. It's a frustrating thing. I mean, I'm an academic and do a lot of research. You can spend decades looking at something in the laboratory and publishing, 5 or 6 papers, peer-reviewed, etc. But then it can be shot down in an instant because someone's got a belief that something happens. And how do you counter a strong personal story versus data and science? And I don't have an easy answer to that, except to keep saying, look, I understand you've heard that, but actually this is what the data shows. So that's my approach to it. I don't know if that's right or wrong. I think complex things like, inflammation, immune response, they're concepts that are difficult to put into plain language and explain to people. I try my best as a scientist and as a doctor to kind of communicate that. But the power of it in individual case reports or someone's, torrid emotional story about, some complication related to cosmetic surgery will always make the headlines and capture attention. So I think it's a balancing act. You've got to balance the power of social media to push certain things, which may or may not be true, versus a slow process of gathering the data and the information, the evidence to say, well, actually, this is what should be the right way to go.
We've noted that you've spoken about educated consent versus informed consent.
Mm-hmm.
Can you explain the difference and what this means?
Of course. So informed consent is something that, as part of any procedure, if you're signing up for surgery, there's a piece of paper that says, Mr. So-and-so has agreed to this procedure. I've explained the risk. The patient signs, the doctor signs, right? And that sits in the notes and, informed consent's done. When you go back and say, well, you've signed this consent form, what do you understand about this procedure? Most of the time people have no idea. So that process, a piece of paper with a signature on it and the name of the procedure, I think is meaningless, right? It ticks a box, but it doesn't actually serve its function. So I like the term informed educated consent because what it means is that the doctor has taken time to educate the patient and understand what they're signing up for, what the risks and the benefits are, not just of the procedure, but they've actually taken the time to say, well, actually, you don't have to have this operation. Particularly in elective surgery, the stakes are pretty high. You're taking a normal person and subjecting them to risk. So, one option is to do nothing. Get on with your life, right? So that non-surgical option should actually be articulated very clearly and the patient should understand that as well. And so an educated consent refers very much to using the right language. The health literacy of the community varies significantly. You have some patients that are very health literate and have a level of understanding that is very high. They read a lot, they understand a lot, that they've thought about it and they can understand some of these concepts. There are others where the health literacy is low. And so the language you use has to be catered to allow for that. And that educated part might mean for some people, 2-hour discussions over a long period of time, using complex language that you hope that they understand. In others, it's using very black and white terms. You could die, you could get cancer, you sure you want to do this? So it's that level of where you pitch that information, I think is really important. So that bit, I think, is the educated part. And the consent is that once you're satisfied as a doctor and the patient's satisfied that they've understood, and that, I don't think that can be done in one session. I think it's got to be 2 sessions minimum, sometimes more. Then the paperwork is signed, but it's not so much the paper, it's the process. And so I like the word educated because it reminds doctors that you have to vary your language and your message in order to be able to get the patient to understand. And even sometimes, I'm not 100% sure that people fully understand, and then I might meet them a third time and say, look, and time is our friend here, right? So there's no rush for this sort of stuff. So use time as your ally. Go away for a month, come back if you have questions. If you really want to proceed with surgery, have another conversation with me. And if that time I'm still not satisfied, then you know what, I really think we need a break for a little while. You know, let's catch up next year and let's talk about it again. So, you know, to me, I think the urgency to rush for things, particularly if as a doctor you're not 100% sure the patient gets it or accepts it, then just put the pause button on and come back later. You're not losing anything.
We've heard that some practices put the risk statements essentially in an online form, so they send you a thing that you click through, and we've heard that there's some science around that people actually process things better like that. What are your thoughts?
You can't do it by proxy. You can't do it as an agent. You can't have some nurse going through, here are the risks. It's got to be the person doing the procedure. They've got to take responsibility for that process. It can't be handed off to someone else or an online form. I feel very strongly about that.
We've heard of instances where patients are having their consult with their doctor and it hasn't lasted more than a few minutes. Mm-hmm. What do you think from your experience is the amount of time a patient needs to be properly informed or educated before proceeding with their surgery, whether it's through one or two consults? But just for those listening who haven't had their first consult yet, when should there be alarm bells ringing in terms of the time period?
Yeah, look, that's a good question. But for my sins, I do a lot of revision surgery, right? So I see a lot of women who've come through the system, have some significant complications, not just physical ones, mental, emotional, financial burdens as well. And I often ask them, because I'm curious, you had your surgery with so-and-so, when did you see them first? What was the consult like? And it does worry me when, their initial contact and decision to go with surgery was a matter of 5 or 10 minutes, right? So that would really worry me. I'm a reasonable doctor, but I can't do that in 5 minutes, So I think for something like elective cosmetic surgery, where essentially a person is normal, they're not suffering illness, right? The surgery is not going to save their life. It might improve their quality of life, maybe. That process to me can't be done under 45 minutes to an hour. I think that, and that's just me. Other people might be better than me and can do it quicker, but 5 minutes is definitely too little a time to transfer all that information, particularly around breast implant surgery, as we've discussed. There's medium to long-term risks that the patient really needs to understand and accept. I think the other thing is I always worry when they see the doctor and then they proceed with surgery, it's usually a matter of weeks or days, right? Because there is no time to reflect and digest that information. So I think a second consult spaced out over some time, and I think the AHPRA guidelines put a time limit on that, I think is a good idea. You might see the patient for an hour, they go away, they think about it, and then you see them 2 or 3 months later for a second equally long consultation. At that point, there's still the pause button, right? So if the patient is not sure or you're not sure that they've fully grasped and accepted the information, there is absolutely no urgency to proceed with elective cosmetic surgery. So the 5-minute thing does worry me. Is it somewhere between 5 and 45 minutes? I would err towards a longer period of time.
The new AHPRA guidelines say that for our medical regulator here that you've got to have 2 consults and one can be virtual and one must be with the surgeon doing the surgery. So what we've seen now is a shift where they're essentially doing a virtual consult with a nurse and then you come in for the consult in person with the surgeon. So the surgeon's not seeing you twice.
Well, I'm not over the guidelines as much as perhaps you two are, but I would have thought that's not quite right. I mean, the actual person performing the procedure should have 2 consults. That's my understanding of it. So it can't be done by proxy. It can't be outsourced. And ultimately, look, I understand in some patients that are remote, that don't want to make a trip to metropolitan area and have incur expense and time. It'd be okay to do a virtual consult. But I think that where possible, I think to face-to-face consults. And once again, it's difficult to assess anatomy and examine the patient virtually, I think. There are things about it that make me a little bit uncomfortable. Certainly, I think it shouldn't be done by a proxy or a nurse or a practice cosmetic consultant or something, and then cut down on the amount of time that the surgeon actually sees the patient.
what conditions might stop somebody from getting breast implants?
There are certain things that are a no-go zone, right? So if someone walks in and has an acute infection, like a urine infection or a chest infection, you've got to cancel the surgery, right? You can't put a foreign device in someone with an active infection. You can't do it. Certainly, there are women who have had who are pregnant, who are still breastfeeding. You can't put breast implants in those breasts. So that's like completely contraindicated. And then obviously if someone has breast cancer. So every now and then you see someone who's gone through a screening, who's had surgery and then has a screening process and there's a missed cancer. So that happens. So it's important, particularly in older women, to actually examine the breast, have a mammogram ultrasound to make sure we're not, having surgery that potentially has active cancer. They're kind of the top three. But then there are a whole other things that don't necessarily mean you can't have surgery, but increase the risk. So things like previous radiation therapy, any immunosuppressive drugs that increase the risk of infection. These are things where you really have to, go slow and say, look, these things increase the risk significantly. Are you sure you want to have elective surgery? There are things like active autoimmune disease. Once again, there's this question mark of whether autoimmune disease and breast implants are linked, and there's ongoing research that we're doing on that. But once again, if someone comes with florid active autoimmune disease, it's not that I won't do surgery, but I will go through in detail. Look, there is this link. For 10 years, implants were banned because of this in the US. We're now seeing these women with symptoms. Are you sure? Just be aware of it. It's a relative contraindications. And then, of course, there's weight loss, weight gain. So we see a lot of patients now, having had bariatric surgery or on weight loss medication. I would not necessarily proceed with any breast surgery until they hit and maintain a target weight. And it's also important to say, if you are going to have breast surgery, then don't gain or lose weight afterwards, right? Particularly lose weight. I've had a few patients that become extreme athletes and take up F45 and stuff, and it really changes the result after surgery. So these are things, once again, you explain to patients. There's a big area that I think AHPRA are trying best to get on top of, and that's the psychology of the patient and whatever sort of I find interesting. So what has brought them, into your office to talk about elective cosmetic surgery? And I think as surgeons, look, we're not the best equipped to, pick up things like anxiety and depression and body dysmorphia and things. So there is this kind of, global assessment initially, but I think if little hairs stand at the back of your head, this patient's probably not, it's not the right time for her. She's got a lot of other stuff going on. She's divorced. She's got this, she's got that. Adding surgery is another stress. So I'm going to say it's an absolute contraindication, but I think we need to be mindful of what's going on in that patient's life and in that patient's head.
Just on that, you were talking about how if you have breast implants and then you sort of get on a health kick, so you start doing like HIIT workouts at F45 or something like that, what can happen?
Well, I've had that personal experience. I mean, nothing wrong with getting fit, absolutely. If they want to exercise, that's fine. But what happens is they lose a lot of fat. The breast is like fat and breast tissue. Essentially, all that padding around the implant goes. The worst case is they become like rocks and socks. So it's like there's nothing camouflaging the implant. So you see every little groove and ripple. Often the breast drops as well. So it's one of these things where if we are going to do surgery, this is something you explain to the patient, Are you trying to lose weight? Oh, yeah, I'd like to lose 10 kilos. So we'll come back after you lose 10 kilos and then we'll talk about it, So that's one of those things that's should be made clear right at the beginning. It's part of that process that I talked about.
Looking at risks now, further into risks, some practitioners who perform breast augmentations have told their social media followings that the worst thing that can happen is an infection. You can die, right?
You could, yeah. I mean, acute infection around implants is unusual. It's rare. But when it happens, it's devastating, yes. And usually the timing is around like the first 3 to 5 days after surgery. Sometimes you can have a late infection. So the infection we're talking about is like redness, swelling, pus. And yes, I mean, if that happens, you've got a very slight chance of salvaging the infection if you get on top of it early, but that involves a trip back to theatre, more cost potentially, washing out the pocket, antiseptics, antibiotics, and even doing all that, chances are you probably lose an infected implant. There's no point leaving an acutely infected implant inside, and you'd probably take both implants out in the setting of cosmetic surgery. It happens rarely and it's devastating, but that's once again a risk that the patient should understand. The infection we talk about in terms of driving contracture, this low-grade grumbling infection, biofilm is the bacteria and the sticky stuff that sticks on the implants. That's not something that presents acutely, but can present years down the track. So I'm very, the concept of bacteria attachment to medical devices, breast implants and other knee joints and other things, that's been a focus of my research for, more than 3 decades now. So it's something I think I'm very aware of in the operating theatre, and particularly when dealing with implants in the operative setting, that, we are putting a permanent prosthesis into a patient. We need to do all we can to reduce the risk of bacteria attaching onto this device. And that level of paranoia scrutiny needs to be a lot higher, particularly in the cosmetic surgery space.
We've heard of cases in Australia where the nipple has actually died through breast implant surgery. Is that true? Can the nipple die and fall off?
Yeah, so it is a risk, and absolutely not just the blood supply of the nipple, but the nerve supply of the nipple as well. So not uncommon immediately after surgery with a swelling that you lose feeling, but you would hope that most of the sensitivity of the nipple comes back. But certainly nerves can be stretched, damaged, cut, and leave you with permanent numbness or reduced sensation of both nipples. Loss of blood supply to the nipple just from a primary augment is rare, theoretically possible, but I think you would mention it, but I wouldn't be too worried about it. It's where, and this is not my favourite operation, where an implant is put in and a lift is performed at the same time. So it's called an augmentation mammoplasty, augmentation mastopexy. Augmentation is the implant, mastopexy is the lift, and you're combining 2 operations in the same setting. The reason it's not my favourite operation is often these women are presenting because not only have they lost volume, but their skin, the tissues have all been stretched and there's no integrity to those tissues. And so you've got 2 things fighting against each other. You want to put volume in, but the volume is also going to fight against the fact that there's no support. So it's an operation that's pulling you in 2 different directions. It's actually, I do a reasonable amount of medical legal work, it's the commonest operation where surgeons are sued as a result of a poor outcome. So if you're putting an implant in and you're doing a lift, you are then relying on taking the nipple and moving it upwards on its own nerve and blood supply. And if you put too big an implant, or if you're not careful with your dissection, then you can lose part or all of the nipple, which is a devastating consequence of an elective cosmetic procedure.
How dangerous are implant ruptures?
Implants can rupture for probably 2 reasons. There's what's called a silent rupture. So once again, I've seen this in my own practice because people come back every year and they come back and you examine them. It's a great result. Everything's fine. And then you look at the ultrasound report and it says left implant rupture and you go, oh my God, that's weird. So those early silent ruptures are clinically not apparent but only picked up on ultrasound. There's 2 reasons for that. One is a device failure. So the shell, for whatever reason, was weak and is broken. Well, the implant manufacturers will cover the cost of a replacement implant for that. Yeah, so that's a manufacturer's warranty issue. If you see someone who's had surgery 6 months ago and you see a rupture, I think a lot of that is because of mishandling of the implant when it goes in. So it's probably damaged the implant by the treating doctor, and I've certainly seen that through the implant check clinics. So that's, I guess, an operative error or an implant problem. The third reason for rupture is because of contracture. So as the implant becomes hard, the capsule around, the tissue around the implant becomes like a scar tissue. It squeezes the implant. On the out, starts to cause pain and deformity. That's clinically what's apparent. There's actually a scale, a Baker scale, which we use to grade capsular contracture from 1 where you can't even feel the implant. So if you're examining an augmented breast, you couldn't tell there's an implant there, all the way to 4, which is where they're hard as rock and, causing immense pain and deformity. And so as these implants become squeezed, the shells get folded. So you can see that sometimes on ultrasound and say, oh, there's some increasing folds here. The benefit of seeing your patients every year, you can sort of track some of these things. And then eventually those shells weaken and then rupture. The first stage of rupture is what's called an intracapsular rupture. So whilst the shell is broken, the contents are still contained within the capsule. And so, it's something that needs to be fixed, but doesn't have to be fixed, tomorrow, right? So If we pick up an intracapsular rupture, it's a discussion saying, look, this implant has ruptured, it's contained. Always, with all patients, I say examine your breast every month, same time every month, and if anything changes, call me. So that, once again, is part of the informed, educated consent. Surveillance is not just by the doctor, but also by the patient. Occasionally, the contents leak out through the capsule. That's called extracapsular rupture. So now we're talking about a situation where the implant's ruptured, but the gel or silicone or whatever has managed to work its way out into the breast tissue. And that is, it can vary. Sometimes it's silent and you feel a big lump on the breast, which is a worry. But other times it can cause an intense inflammatory reaction. So the breast becomes red, painful. And that's one of the few times where I'd say, we just got to get this thing out quickly. The danger of leaving an extracapsular rupture too long is that it eventually damages the breast tissue, silicone leaks everywhere, and ultimately to clean that out involves almost like a mastectomy and causes major problems. So, once again, the simple act of saying to a patient, this is not going to last forever, it might rupture, come back every year, I'll examine you, I'll do imaging on you. Heaven forbid if it was to rupture, let's get onto it early and not leave it till it becomes a major problem.
When you travel with breast implants, do you need to carry some sort of card to say you've got a device in you, or prepare yourself with, say, travel insurance that would cover things like that when you go overseas?
That's a good question. I hadn't thought of it. I haven't asked patients, or patients haven't asked me specifically for a letter saying I have breast implants. I don't think many people want to broadcast that, or some of my patients don't. It's look, if you're traveling and you're carrying implants, there's always a risk that something could go wrong overseas. Just be aware that in some countries there is no Medicare, right? And particularly in the US and even in Europe, anything resulting from cosmetic surgery is not going to be covered. So you could be up for huge costs if you had some major complication whilst you were traveling. But that's a good point. I hadn't thought of that. Maybe we should include that in our informed, educated consent checklist.
For the women listening who do have breast implants, maybe they're starting to feel like maybe they do have symptoms or something. At what point would you recommend that they actually go to their doctor to get checked out?
Well, I think all women with implants need an annual check, even if they think nothing's wrong. I've said that for many years now, and I'm trying to slowly get my colleagues to sign up for that. And it shouldn't be done by, once again, a proxy. It should be done ideally by the surgeon who put them in, because then they take responsibility for the device today, tomorrow, next year, in 10 years' time. So I think, to me, that's what I do, and I think it's a good standard of care. I think a lot of patients relax because they know they're going to see me in a year. It should also come with the advice that we talked about. Examine your breast every month, get to know what they feel like. If anything feels abnormal or looks abnormal, come straight back, because sometimes these complications happen in between the interval times. So it's about educating women about that as well. Ideally, it's an annual check. Imaging looks somewhere between the first 2 to 5 years, because if they're young, there's no need if clinically they're okay. The FDA in the US has mandated imaging within 5 years to look for silent rupture. And then certainly past the age of 40, you incorporate breast cancer screening. So one of the interesting things we found when we opened the Implant Check Clinic is a lot of women were informed that now you have implants, you can't have a mammogram. That is actually wrong and dangerous, right? Because you need both a mammogram to exclude breast cancer and you need the ultrasound to check the implants. The two things are complementary. And so you can actually have a mammogram if you have implants. You just need to tell the mammographer that you have implants and the techniques that they use to protect the implant. And so that it's dangerous, because if they were told that and they don't get mammograms, then breast cancers are missed. So interestingly, when we opened the Implant Check Clinic, we did find a few breast cancers that had been lurking about because women were told they can't have mammograms. So it's these little things that I think you're not even aware of until you start talking to women with implants, and the level of understanding and information they have about these devices is minimal, which is scary because it's their body, right?
That's shocking to me that women were told not to get mammograms. Is it just because there was that fear that they could rupture?
Mm-hmm. Yeah. So look, if you had a Baker 4 capsule and they were as hard as rock, it would be very uncomfortable and it possibly could lead to a rupture. So in some women, you'd say, look, it's probably not a good idea to have a mammogram, but the majority of women should have mammograms. But once again, it goes back to the point that if this is information that was told at the beginning of something that you need to do, why would you not do it, right? If you had this lifelong commitment and contact with your own patient, it I think it's actually quite nice to see patients I've operated on 20 years ago once a year and, find out what's going on and, make sure they're okay. I mean, it's quite a nice consultation. But also it forms a point of contact where new information can be disseminated. So particularly when this ALCL risk was discovered and certainly we had some media stories on it, I knew that the patients are coming to see me every year. It was a way of telling them, look, you will read about this in the newspapers. Don't panic. Your device is a low-risk device or it is a high-risk device or whatever, but just come back every year and these are the things you need to look for. Because, look, I've been researching these devices for some time, but there'll be other things, right? So if you know there's a yearly visit, you go, I should remind my patients about this. This is new. We need to check for that. And so I think that lifelong surveillance, contact and care is an essential part of this whole process.
I think that's an important point because patients probably think, well, I'm fine, I'm not having any symptoms, I'm happy with the way they look, so I'm not going to go make my annual appointment. But that's a really good point in that there's always new information coming out, there's always new research. So if just for that, they know that they can get proper scientific information from their doctor, if nothing else.
It also, I think, makes them less likely to fall prey to misinformation because they know I'm seeing, my surgeon in 3 months or whatever, read this thing in the paper. Look, there's no doubt when the media talks about some breast implant crisis that, a lot of people ring and want to get information, which is absolutely fine. It's understandable. I'm very good at disseminating information about research and about guidelines and about position statements and things. We've recently published one on the systemic symptoms issue. So we often point patients to that. The other point of call, let's say your surgeon's retired or there's no offer of surveillance, is your GP. So I've been working very closely with the Royal Australian College of General Practitioners and we have resources to train GPs on complications of implants because once again, it's not something most GPs would know about. The idea is that we have a framework of support for women with implants and that they're not afraid to seek information, assessment, if they need it. But even when they don't need it, that system is in place.
Given your work at the breast implant check clinic, you would see a lot of patients coming in that have had other doctors work on them. How common is it for someone to present without any issue except for the fact that they're not happy with the outcome?
This is in the paper we wrote. So the implant check clinic is not going to see someone who's happy. So we tend to, people are worried or they have a problem, that's why they come to the clinic. And there's nowhere else for them to go. Their surgeon's offices are closed down, is retired, is fled the country. So, that they'd come to us as a way of at least getting their problems sorted. So there is a selection, what we call a selection bias in research. We're not saying every woman out there has had problems, but we are seeing a lot of problems in the implant check clinic because that's what we're set up to do. In terms of, looking at the overall population and satisfaction rates after augmentation surgery, there's very little long-term information. Manufacturers, when they get their implants approved, have to do what's called a post-market study where they're looking at, obviously acute complications, medium to long-term complications. And the problem with a lot of cosmetic patients is they're very difficult to bring back. They're itinerant, they might move cities, move jobs, and that you lose contact with them. So I think it's the medium to long-term satisfaction outcome data is simply not there. And we're sort of guessing. That's why I hope that things like the breast device registry, ultimately by capturing every implant going in Australia, will give us that data. It might take another 5 or 10 years, but then that'll be the benchmark. The true satisfaction rate for cosmetic augmentation is at 5 years is 50%. Flip a coin. Should we be doing it, Or should we be telling patients to be happy for 2 years and then you're not going to be happy, So, that's the kind of data that'll be really interesting to see over the next few years.
One of our pain points has been social media and the way these procedures, including breast implants, are being advertised. So if a patient jumps on Instagram and TikTok, they are pretty much exclusively going to see curated results of happy, positive outcomes where the women look perfect. They look beautiful. And then there's this lifestyle that's being attached to it. They're on the beach, they're in a bikini, they're holidaying overseas. It almost gives off the impression that there is no risk because you often don't see any risk statement either. Is there a message you want to send to these patients who are relying on Instagram and seeing all these beautiful results?
Well, look, I've been very vocal about this issue. I think I wrote my first opinion piece in the Herald many years ago, and it was actually triggered at a cosmetic surgery conference where I was sitting in the audience, and I heard a talk from one of the practice people talking about how conversion rates and using this particular strategy we can get more people to sign up for surgery, and this is the way to become busy and make more money. And then the next speaker was a psychologist, and she got up and said, look, we may be actually harming some young women with this sort of message. So there was this complete, like one talk and then the other, right? And I mean, first do no harm. That's one of the principal tenets of medicine. I just became very despondent. I was like, is this what we've been reduced to? How to convert patients when in fact we should be actually looking after them and informing them. So that, in a fugue state, I got home and I just wrote this article and I sent it off to the Herald. It pretty much focused on that issue. Are we actually causing harm, by doing this, by portraying an image, by underplaying risk, by preying on vulnerabilities, by, almost selling a dream but not actually telling them that there's no way that either that dream is going to be achieved or is in fact sustainable. Because if you actually look at your results over time, they don't look like those images, right? And in fact, it was brought home to me because, I have two daughters. They're in their 20s now. They were younger then. And I was like, what are we doing to our young women? Like, why are we putting them under all this pressure? It was kind of a heartfelt opinion piece. Like you send your opinion piece and you don't hear anything. And then I got a call from the editor saying, we're running your piece. And I'm like, I hadn't edited it. I just literally sent it off. And then it was published the next morning. And then, of course, the phone rang. Can you write this? So it was kind of my first it was not out of any malice. It was just the way I felt after I heard these two talks. And then since then, I've become quite vocal about the damage that sort of thing can cause. And then, of course, my practice involves seeing a lot of these women for revision surgery. And so I spend a lot of time with them. And I feel sorry for them. I want to help them. But it's much more difficult to help someone after the fact. If you can stop this happening in the first place, then you wouldn't be having to deal with some of these difficult, patients and problems, today. So it led to, a series of articles and talks talking about, the dangers of social media advertising, the use of influencers, influencer marketing, some of these really, even cosmetic surgery information websites and how, certain surgeons are promoted over others through payments. It's all a commercial thing, right? It might work for selling cars or real estate, but this is healthcare, right? It's not the same. You can't use those sort of aggressive marketing tactics to sell health. I feel very strongly about that. And so, look, I was kind of first out of the blocks, and then obviously, the recent media stuff has been amazing in terms of exposing, some really terrible practices, not just from advertising, but from a patient care point of view. And so, when the APRA, guidelines and things were being proposed, I actually wrote a big submission, interviewed by Parliament about it. And one huge section was all about advertising. The sad thing is that if you go back a few years, APRA actually released some guidelines on medical advertising and, talked about, being truthful and use of images and things, but they didn't enforce them. So it was almost made it worse because here's the standard, but then if the standard's not enforced, people go, well, it doesn't really matter. It's free for all. So I'm sort of cautiously optimistic now that through both your work as well as the work of the regulator that we're actually beginning to understand the impact of some of these practices, and hopefully it'll be a thing of the past. But it's not going to be an easy road, because I think it is a commercially driven business. You can't get away from that. At the end of the day, the commercialism and its impact on vulnerable women and ultimately on their lives and in their health, that nexus has to be broken. It's nice to have been, played some small part of that. But at the end of the day, in a few years' time, if this is all history and we talked about the bad old days when social media was unregulated and a lot of women were harmed, then that'll be a good thing.
Your advocacy has actually been really important. We've found it quite difficult to get medical practitioners to speak out about this kind of thing. When you talk about the regulator not enforcing what they were seeing on social media and in advertising, we're actually getting the regulator on this podcast as well, and we're going to be asking some questions around that. But I also think it's kind of ridiculous that they had to write down that doctors can't put their patients in lingerie.
I actually think it's demeaning, right? I mean, it shows it's a lack of respect, I think, for women. I think, I don't know, maybe I'm a bit old-fashioned, but it's I can't reconcile using images like that if you actually respect women and want to help them. Do you know what I mean? Like, or you understand what they want or what they're going through. I don't know. I feel there's a real you don't want to think worst of people, honestly, but it's just preying on vulnerabilities, and I think that's to me that's unacceptable if you're a doctor.
In Australia, surgeons have done semi-nude and nude photo shoots for not with their patients, but they've got their patients in to do them, and trying to get other people from the medical community to be concerned about that was more disturbing, because a lot of people are saying, "Oh, that's just the cosmetic surgery industry."
So there's definitely a line, right? And I've thought about this a lot, because I think there are certain, I guess, values and ethics that I've been brought up with, and play strongly in my everyday life and practice, right? But I think, that maybe there are people that are untethered from those values or have different values or don't even see it as wrong, right? It's a difficult thing because, I can't get into the heads of some of the, and, even talking about it makes me feel like, oh, that's ridiculous. But maybe to some of these people, they're so far away from the norms and the values and what's right and wrong that they don't see any issue. Is it, the shameless pursuit of profit and commercialism or narcissism or whatever it is? I don't know. I just feel sometimes, the outliers in this industry are so removed from normal life and, what's right and wrong, but they don't even see it. And even having some conversations with people, not necessarily right on the edge, some colleagues who perhaps are pushing the boundaries a little bit. And I've had conversations with some of my colleagues saying, I really think that's a bit too far. And what's wrong with that? Same as so-and-so, he's doing it. There's nothing wrong with that. So it's one of these things where you can regulate and you can say, oh, you can't do this, and have a very, as you say, a very specific line. You cannot have lingerie. Oh, we can't have lingerie. You can't use emojis. What? You can't use emojis. I mean, it's sad that you have to be that specific, right? I have a feeling that the majority of us want to do the right thing and do the right thing. Unfortunately, the outliers, the people that have really, pushed the boundaries and dragged this industry to places that I never thought it should go, are the ones that capture the headlines. And certainly I think you could give the impression that it's all bad. But I don't think the majority of us want to do the wrong thing. I can't believe that. And hopefully the majority of values and ethics are where they should be. But there certainly are people and conversations that I've had where you feel like, I don't think this person actually understands what's right and wrong. They're so far removed. Maybe they started with some grounding, but now they're off, way off the charts and the scale. They don't even have any idea what's good or bad. They're motivated by something completely different.
The argument that we've heard is, well, these photos, these women sending us their bikini pictures, lingerie photo shoots, it's empowering. It's empowering to women. And we've come across this quite a lot. I think that is a way of sort of convincing women to agree to do social media marketing because it's going to be empowering other women. Our thoughts on that are they told that these photos are going to be used in advertising to vulnerable people, to young people? It could suggest that people aren't sexually ready until they've had breast implants and other types of cosmetic surgery. It's like it hasn't actually been spelled out to them what this means to be sending through their photos for cosmetic surgery advertising.
I think that's part of it, yes. Certainly some women may not be fully aware of what their images are going to be used for, but I also think don't underestimate patients wanting to have their images out for other reasons. So, influencers, the rise of influencers, peddling all sorts of products on the internet, particularly through social media. there are some other more ulterior motives to getting their images out and building a following. And certainly, those of us in the industry have been approached by, some influencer with hundreds of thousands of followers. Do my surgery for free and I'll promote your practice, So there's many reasons and motivations for patients wanting their images out, and they're not all necessarily, I didn't realise. Some of them actually realise very much, and it's a deliberate thing to build their own value as a brand or as an influencer.
Do you think that a surgeon should be asking their patient to send in photos to their mobile phone of just how are they looking, that it's not clinical photos, just like send us a photo of you on the beach, or send us something like that? Or even should they be communicating at all via text message in that way?
Communication comes in all forms, right? So there are certainly some patients, particularly if they've had complicated surgery, I say, look, get in touch either via email. I don't usually give up my mobile number to patients. Every now and then, maybe it's more because I'm worried, are you okay? Reach out to me at any time. I think it's got to be kept on a clinical level. You're the doctor, they're the patient. They're not your friend, or, you don't want to see their holiday snaps or whatever. And certainly, social type photos, I don't see a role. But certainly if they're worried about a wound or whatever, I say, well, send me the photograph on email and have a look at it. That's okay. I don't have an issue there, because it's part of clinical care. It's part of how we communicate and make sure patients are okay following surgery. It's one of those things where the doctor-patient relationship is one, there is a power imbalance, right? You got to accept that. Patient comes to you with a problem, not just in cosmetic surgery, but they have a health problem. And you as the doctor have the knowledge and skill and hopefully the ability to help them and do that. But that's the way the relationship is set up. And once again, you have to be respectful for that, about that. You're there to help the patient. You're not there to help yourself. And so to me, when you say, send me your holiday snaps and stuff, that doesn't sound like a doctor-patient relationship there. And you've got to question, well, how is that a therapeutic move?
So they send in, the kind that we see, and the reason we know is because not only do the doctors seem to think this is appropriate, and we're talking about doctors in Australia as well as overseas, but they then will screenshot their phone and publish that on social media. Oh, look what my patient just sent me. So you'll have a woman, sticking her cleavage out in a little tiny piece of lingerie, and then you'll see the doctor's reply, oh, they look great, or, like perfect, or some emoji, and or hot, lots of love hearts.
Right. But what's the motivation for that, Michael? Honestly, what's the goal there? Why would you put that out? Why is this doctor seeking out that image, and why is that doctor promoting that image? Is it to get more work? Is it to tell people all these patients have surgery are hot? I mean, I don't, that's not my motivation. So once again, it goes back to, do they see that is wrong or not? They may not see that as wrong at all, and that's my problem here, is that the majority of us come from a place of, I guess, shared values, shared ethics. The reason we did medicine was for, to help people, or to help people in need, or, treat difficult problems or whatever. Ultimately it's to serve the patient, right? In whatever area of medicine that you practice. This is not that. It's not medicine now. It becomes sales or marketing, or I want this, or I want more patients to see that I can have, wonderful cleavage, So I don't know. It goes back to that underlying, why is this doctor doing that? Is this part of treatment, or is this part of business or marketing? And I'm being a little bit black and white here, because I think, as a doctor, you do run a business, and you've got to pay the bills and staff and rent, and, we know all about that. But that shouldn't be the prime directive, right? That's where I think you start to lose your way as a doctor. So to me, healthcare is always about serving patients. And if you serve patients well and you're a good doctor, the commercial success comes as a secondary effect. It's not the prime directive. So to me, that sort of behavior smacks of, well, it blurs that doctor-patient line, but it also, by broadcasting that through whatever channel, social media or media, it's trying to send a message to other patients, come to me because I'm the best, and look at my patients, they look great. That's not the sort of image that I think we should be doing in cosmetic surgery. Or the sort of message we should be sending out in cosmetic surgery.
Circling back just to the risks, without identifying anyone, is there a breast implant case that particularly shocked you?
There are so many. As a group, I think the worst that I've seen are the TCI patients, the Cosmetic Institute patients. So the Cosmetic Institute was this clinic chain that was set up, started in Sydney and then spread north and south to our states here in Australia. And, the thing that sticks in my mind was breast implants for the price of a cup of coffee a day. That was kind of the advertising thing, glossy images, bikini shots, all the stuff we talked about before. It was set up to be a sort of cut price clinic. So they offered, I think the total cost for augmentation was like $6,000. And of course, if you didn't have $6,000, there was a finance company next door or whatever, and you could sign up and pay it off in installments. So they targeted a lot of women who, A, shouldn't have had the surgery and B, couldn't afford it. And then the surgery was done but not by surgeons, but by doctors who were given basic information about how to do the surgery, oftentimes on video, right? So then they were let loose. So the clinic, at its height, I think, put in a lot of implants. I think it was like 5,000 implants a year in Australia went in through TCI. That's a quarter of implants in the country. And clearly, if you cut the price down and, advertise heavily, you'll get people signing up. What became clear actually fairly early on was that the surgeons were not skilled. There were some very serious complications. People end up arresting in an intensive care from overdoses of anaesthetic, people seizing on the not operating table because it was essentially a clinic, like not even a hospital. And then, as with all breast implant surgery, problems started to, delayed problems. So now we are facing thousands of women that have had implants that are placed in the wrong position, that are too big, too small, they should have had other surgeries, that have got ruptures. 3 of them actually have developed this rare lymphoma because, heaven forbid, the implant they used was the high-risk textured implant that's now no longer available. The cases before the courts, there's a class action proceeding at this stage. And the aim, hopefully, is to win some justice back for these women, but also give them access to revision surgery, which all of them will need at some point.
Can you share some of your findings on breast implant illness the research that you've done on that?
Yeah, of course. Well, for a start, I don't like the term breast implant illness. I know it's out there and absolutely fine if people want to use it. But once again, putting my research hat on, ultimately, if we're going to use data and evidence to kind of work out what's going on, the more appropriate term is called systemic symptoms associated with breast implants, SSBI. So slowly but surely I'm trying to socialise that term. The regulator's now using that term as well. So it's not a new story. We touched on it before. Back in the 90s, some case reports were published in literature. Women had implants and developed sort of autoimmune type disease. And the story goes back even further, actually. After the war, Japanese prostitutes catering for American soldiers' preference had silicone injected into their breast to make them bigger. And some of them ended up with silicone adjuvant disease, which looks like autoimmune disease, severe joint pains and all sorts of things. So the link between silicone and autoimmune type diseases, goes back way before breast implants. So when these case reports came out, a lot of women said, I've had implants and now I feel terrible. I've got, fatigue, joint pains, etc. So that was all dispelled after some big population research, but it's been bubbling away. And I think coincident with a lot of the regulatory action around breast implant lymphoma that we talked about, particularly through social media, people started sharing their experiences. And once again, there's nothing wrong with that at all. But it became clear that a lot of women with implants had a range of symptoms that affect head to toe. And more interestingly, when these women presented for surgery and had their implants and capsules removed, they reported feeling a lot better. Like a lot of their symptoms disappeared, they got their energy back, etc. So I became interested in this as a flow-on from all the stuff we've done on implants. And we started a study here in Australia, one of 3 studies actually going on, one in the US, one in Europe and here. And we've amassed around 300 women now into the study, which is terrific. And once again, to try and sort out what's going on, we collect data. So the aim of the study is that we document all these symptoms that women have. we do have to, very importantly, check for underlying disease, because a lot of these symptoms may be related to an iron deficiency or maybe even real autoimmune disease, or so they have to go through a period of proper assessment. We need to exclude other things that are causing the symptoms. And every now and then you find, I found a patient with multiple sclerosis as well that had been missed. So you have to be a real doctor, making sure that we're not dealing with another disease process. And then, yes, if they do want their implants and capsules removed, we do surgery. Being once again very fascinated about what happens with implants is all the implants and the capsules and tissue are sent to our laboratory where we look for signs of inflammation. And then we track what happens to them after the surgery. And we have a group of control women. So when you're doing research, it's always good to have another set of patients that have implants coming out but don't have the symptoms. And we want to look for differences in their blood tests and their pathology, etc. So I'm about to present the findings actually this afternoon at our annual meeting. And I've presented these around the world and the papers should be published soon. But the take-home messages are that 85% plus of women that have these myriad symptoms do benefit from having the implants and capsules removed. So that's the first thing. And that's important because when it first started coming out, there was a lot of skepticism. Oh, it's in their head. It's not real. It's just menopause or whatever. So one thing I think I've established is that, no, there is something going on and there is benefit to surgery. So I think that's good. The second important finding which I'll present is that for a little while, once again, we talked about the explant industry rising. They were using the term en bloc. Oh, you're only going to get better if the surgeon takes everything out. If they leave anything behind, you're still going to be sick. So the studies, actually 3 studies now have shown that it's not critical to take everything out. You can leave a portion of the capsule in. Not that you try to, but sometimes if the capsule is very thin or it's stuck to your ribs, or in fact, you can actually cause some damage to arteries and blood vessels and leave the patient with chronic pain, then maybe it's not so critical to take all the capsule out. And the data shows if you have a total capsulectomy or a partial capsulectomy, you still get the symptom benefit. So that's good news. We're not subjecting patients to unnecessarily risky procedure if they don't need it. The third thing is, and this is very early, so I don't want to push it at the moment, but we are finding some evidence of inflammation and bacteria within some of these capsules. Still more work to do, but there is a huge overlay of anxiety and depression in these women. So when you look at these women, and you don't know if it's chicken or egg, right? So they develop symptoms, they feel unwell, and then doctors say, oh, there's nothing wrong with you. And that builds up. I feel bad, but everyone says I'm okay. So that's anxious. If I had that, I'd be anxious as well. So whether that's as a result of it or the cause of it, we don't know. But certainly I think there's a mixture of mind and body here. And we've gone back actually, interestingly, and this actually has got a relevance to what we've been talking about. And some of the patients with the worst symptoms, functionally, they can't work, they're bedridden. We've gone back and actually looked at their initial contact with their surgeon. How much do they know about the risk of implants, their informed educated consent process? And guess what? The majority of them felt they had constrained choices. They felt that they never really had the benefit that they were sold. They regretted having implants in the first place. They didn't have the result that they thought they would get. And then ultimately when they started developing symptoms, it reinforced that guilt and that shame. So there's already the ground that's been set for unhappiness. They develop some inflammatory symptoms and the two things then work like an amplification cycle. So that's the theory we're working on at the moment. So it goes back to doing things right the first time. If this was an empowered shared decision where the patient was fully informed and educated, even if some of these symptoms were to appear, they would own that. Oh yeah, the doctor told me this could happen. You know what? I'll just get my implants out. No big deal. But if they weren't told and everyone's saying they're okay and it's in their head, that's not very helpful at all.
Is it true that some patients feel better after getting an explant but then develop SSBI after?
Yeah, so as I said, around 80-85% of people see benefit, and we've only followed our patients to 6 months. So we don't know what happens at 12 months or 18 months. The US study has actually hit 12 months now, and they're reporting a sustained benefit, which is good news, because what you don't want is to take implants out and then all these symptoms come back, and and it's kind of been a waste of time and effort and money. But it's not for all patients, right? So some people do have other underlying drivers of these symptoms that are not the implants. And you make that, once again, informed, educated consent. You make that very clear from the beginning. right? You could be in the 85% of women that we've seen in our study at the 6-month mark that feel better, or you might be in the 15% that do not.
Is there a way that patients who want breast implants can assess their risk for SSBI?
That's a really good question. We're still very early in working out what the drivers are. So, we talked a bit about having autoimmune disease and wanting breast implants. Those sorts of patients, it's not a no-go zone, but you would have to really let them know about the whole context of autoimmune disease, breast implants and SSBI so that they make that decision with that knowledge, right? I think there has been some talk about women, with severe anxiety, right? So anxiety is a terrible condition, and it in itself is a medical condition. People suffer crippling anxiety through life, and I think it's one of those things where if someone had severe anxiety and was already worried about the risks of implants and came to you for a breast implant, once again you'd have to really go slow and say, "Are you really sure this is the right operation for you?" I'm not a psychologist, so I don't pretend to understand how to assess and treat, anxiety, but it would be one of the instances, particularly if I was worried, to say, why don't we organise a psychologist to look at this, maybe get on top of it, and then come back and see me and see if you're still keen.
And last question on SSBI, is there a percentage you can give on breast implant patients who develop SSBI symptoms?
Yeah, so that is an excellent question, and we have no idea. So, ultimately there is a prospective study going on in the States that's about to start, and we're going to track women and do a full sort of psychological assessment before surgery, and once again see if there are certain predisposing psychological factors that might push them to SSBI. Similarly, women with a history of autoimmune disease or family history of autoimmune disease, are they at greater risk? So once again, it's interesting because I've obviously studied capsular contracture, I've studied this lymphoma. In those, the research was relatively easy because we have capsular contracture, which is black and white, and then we go back and work out what might cause it. With ALCL, the lymphoma, you have the lymphoma. Then we can go back and work out what are the factors that drive it. If a patient presents with a range of systemic symptoms covering from head to toe, and they might change actually one week to another, where do you start? What are the likely causes or drivers? So this is challenging research. It's not as straightforward. I have the benefit of working with a huge team with collaborators. And over the 30 years of my academic career, it's been a privilege to work with some really smart people that can help disentangle some complex issues. And so just be assured that, we are working on it. Some of the early data is coming out, as I said, that reinforces those simple messages. If a woman comes in and believes she has SSBI, listen to them. Take them very seriously. Don't dismiss them. Work them up to exclude underlying deficiencies or other diseases that might be causing the same symptoms, and then offer them implant removal.
Do breast implants cause cancer?
Yes, they do. Yeah, so not all breast implants, but the work we've done around this blood cancer, this breast implant-associated anaplastic large cell lymphoma, BIALCL, so it's a long acronym, is directly attributed to textured implants, and more particularly a high risk with the really rough textured implants. So that's actually research that we've done here in Australia. We were small enough yet big enough. We did accumulate a lot of cases in a short period of time, but we also have good records here in Australia. So we could pick up, what implants went, how long they went in for, and then study obviously the tumour and then correlate. So the short answer is yes, textured breast implants do cause lymphoma.
What are the chances of you getting cancer though? Are they very low or and what is low?
Depends on the type of implant. Once again, I'm quoting from our research here directly. So when these reports first came out, we did, once again, like SSBI, we didn't have an idea of the risk, right? We don't know, how many women would develop this cancer. Australia has had a predominant use of textured implants as compared to the US, which is mainly smooth implants. That's for historical reasons. But more and more cases started to come up in Australia. And that's when me and a few researchers became really interested in tracking the numbers. And then we were able to get the implant data, so the implants related to these cancers. And then amazingly, industry was very helpful and gave us their sales data. Now, a few points about the cancer. So it takes 7 or 8 years to develop, so it's not immediate. The presentation is everything's fine, and then one day one breast just triples in size, and it's due to fluid around the implant, and it's in that fluid that the cancer cells reside. And then if untreated, those fluid cells can become a solid tumour, and then they can invade and spread everywhere. So anaplastic is not a nice word. It describes a very aggressive type of cancer. So certainly once the cancer spread, you need chemotherapy and you need immunotherapy, like it's full on nasty cancer. So in terms of risk, what we worked out very quickly was that it was certain types of textured implants. Texture was introduced once again, like 90s, in an attempt to try and reduce capsular contracture. So ironically, introducing a rough surface, people thought the implant would blend into the tissues and grip better and hopefully stay softer. And there's argument whether that works or not. But inadvertently, we increase this risk of cancer. So the greater the texture, so some of the really, really rough implants have the highest risk. And that risk is around 1 case for every 2,000 implants. So 1 in 2,000 is the risk. If you go to implants that are still aggressively textured but not as aggressive as the other ones, it's about 1 in 3,000. And then you go to implants with a sort of softer texture, it's about 1 in 16,000 to about 1 in 60,000. So all these numbers we generated in Australia, so really, really good research. That then fed to a regulatory decision in 2019 to say, okay, well, anything that's 1 in 2,000 risk for elective cosmetic surgery, that's unacceptable. So those implants, the high-risk implants, were removed from the Australian market and worldwide in 2019. As a researcher for many years, you dream of being able to do research that then leads to like a decision like this, right? So I'm not trying to overplay it. There was a lot of other data that came through, but our research fed into that regulatory decision, and it was absolutely the correct decision.
So what's the prognosis for people who have breast implant-associated cancer?
Yes, so the good news here is that Australia is very aware of the disease, and if you pick it up early in that fluid stage, then all you need is surgical removal of the implant. I'm not saying all, it's still a big operation, but surgery alone is curative. And the other piece of good news is, a lot of publicity in Australia. We've educated general practice and the general population to have their implants checked, particularly watch for these signs and symptoms, is that we're picking up women at the earliest stages now. Early on, there were a few advanced cases, and unfortunately we did lose some patients to the cancer. But I think we can be very proud of the way the government, research, the regulator all acted in concert to get the word out, to make people informed and pick up these cancers quickly. And the earlier you pick it up, like with any cancer, the better the prognosis.
I know you said the risk is 1 in 2,000, but do you have a number of women who have breast implant-associated cancer?
Worldwide, you're talking about 1,400 women, so it's not very common. In Australia, look, I was collecting the data, but I've handed the job to the breast device registry, so you might have to ask them what the latest numbers are. When we last tallied, when we were collecting, it was around about 130, so around 10% of the cases around the world, which is high for Australia. Australia's not a big population. So for some reason, we saw a lot more cases in Australia compared to other countries, which also gave us the opportunity to do the good research and the risk calculation. So 1 in 2,000 refers to the high-risk implants. So if you have a textured implant that's currently still approved today, it's around about 1 in 16 to 30,000. The beauty of having good data and science, and to be able to communicate to the patient so that she can make that decision based on evidence. And I think for me, as I say, I do a lot of research, but I'm proudest of this bit of research because it actually has made a big difference.
Well, thank you for your research in this very important field, and I hope that that sort of overview has been helpful to our listeners. We're going to look at the true cost of implants now. So some podcasts, it almost sounds like a sales pitch, so that's not really what we're looking for. Michael's going to go through what we're sort of looking for in terms of the true cost of breast implants.
Yeah, when you see the thing on social media, any surgeon putting stuff out, they say, how much do they cost? And the way implants are sold is always very like easy, simple, quick, there's $7,990, that covers all your costs, very low risk procedure. And usually you don't have to get them taken out every 10 years or whatever. They make it seem really simple and cheap. So here's a thought that we had when it comes to the cost that people might not consider. So in terms of the cost of the initial procedure, cost of time off work, travel, incidentals, potential corrective procedure to refine the result, revision if botched or unhappy, ruptures, yearly checkups, cost to replace it 10 years, if you SSBI costs, unable to work, counselling, GP visits, lost opportunities, loan repayments with interest, accessing your super, so again, interest. What are people looking at from your experience?
I think that's a pretty good list, actually. And I commend you for putting that out, because I haven't really spelt it out. But I say, look, by signing up today, you are going to have more surgery. So that implies that you will be paying for more staff. But I think the way you've set it out and timelining it is quite useful. So it'd be nice to land on an estimate, because as you know, the initial surgery you could pay as little as $6,000 all the way to $25,000 in Sydney. I don't know what costs are in other states. But then you've got to add, as you say, time off work, dealing with complications, revision surgery, annual checks, imaging. You know, if you develop a complication, whatever that complication is, it's going to need more, lead to more medical costs and more surgical costs. So all I can say is that revision surgery at this stage is going to be more expensive than what you paid for your first operation. That's a fact, because revision surgery takes more time. Not only is it more costly, the outcomes of revision surgery are more uncertain. There's no guarantee that if you have a complication, you'll ever get that result back again as well. It would be nice to land on a sort of average. Maybe that's some homework that we can do.
How much does an explant cost typically?
Yeah, so once again, that varies significantly. So explant, unlike an implant, particularly if there's an associated medical problem, well, there has to be an associated medical problem, whether it's a rupture, contracture, or deformity or pain, is actually a medical procedure. So implant capsulectomy can be covered under both public and private health funds. And so once again, pick a number, right? So there are people doing explants in this town for under $5,000. There's some that are getting explants on their public waiting list, particularly if there's a rupture or some serious complication. And then I've seen patients being quoted upwards of $25,000 for an explant with all sorts of other frills like fat grafting. And
just on the fat grafting, when you're having an explant, is it dangerous to be putting anything back in there when you're pulling the implant out, like fat grafting?
Well, once again, I can speak to my practice. I do talk to people about fat grafting. Once again, they hear about it. There are some people that say, oh, I don't do implants anymore. You can have the same result with fat graft. Well, look, they're two very different procedures. Fat graft, the concept is that we take fat from somewhere else and the fat has to be harvested and kept alive and then re-injected into areas of the body, and then hopefully those little fat cells get blood supply and continue to live and then give you volume replacement. It's very patchy, right? It's technique dependent, and you're building into the fact that around 30 or 40% of your fat graft will die anyway because it's very fragile. And it's not the same result as an implant. Often patients will require multiple fat grafts to get to an endpoint, which is never going to be the same. So once again, it's about being honest with patients, not selling them a dream, saying, oh, I'm the fat graft guy and you can have great breasts just with fat. And often it's multiple surgeries and multiple costs as well. It's probably a lower risk operation because you're not using a foreign body, you're using your own tissue. But I think the thing with fat graft at the same time as explant is just my preference is I've found that if you've done a total capsulectomy or even a partial capsulectomy, it's a big space where you've taken the implant out. There's often damage to the tissue surrounding. There's a bit of bleeding. And my concern is putting fat into and around that space means the fat just dissolves and dies. So the other thing I've found is that we have a few tips and tricks that I've learned to try and get rid of some loose skin or tighten up some of the loose tissue after the implants come out. And once again, we're published on this. Around 85% of women are actually satisfied at that point. and don't need any further surgery. So from a cost point of view, a time point of view, a safety point of view, if I can get to 85% of my patients being happy with just an explant plus or minus excision of some loose skin, then why would I offer fat graft in the first place and do that? Maybe in the 15% of people that need something done, yes, you could offer them fat graft. So I've always done it as a stage thing. I don't believe in doing more. I believe in doing less. So if you can get to the same endpoint by doing less and you serve 85% of your patients, that's a good outcome. And actually nothing gives me more satisfaction than saying to them, look, at 6 months or 12 months after your surgery, this is you. From now on, all you need, do your self-breast examination every month, and then every second year get your mammogram, and you're done. You don't have to worry about this anymore. Well, you have to still worry about breast cancer, but you don't have to worry about implants and implant-related complications. It's a nice place to bring someone, particularly if they've had a torrid time with implants through their life.
So we've touched on marketing quite a bit already throughout this podcast. If Instagram isn't the place to choose a breast implant surgeon, maybe your thoughts are it is, where should patients choose their breast implant surgeon?
You know, I think prior to all of this explosion in advertising and marketing of medical services, a lot of good information came from your GP, you know, because they would often refer to specialists and then get the real info in terms of what actually happened as the patient came back. There's an old adage, I think, if you want to build your practice, just be a good doctor, right? There's no need for bells and whistles and megaphones and advertising. So it's a slower process, but it's a more sustainable and I think a truer way to build your reputation and your referral. I don't think there are shortcuts, and the shortcuts always come with, you know, the danger that you're overstretching or, you know, trying to get patients in the door. So what should bring patients into the door is your work and your reputation, and that takes time to build. Ultimately, if you're in a place where your work is well respected, you're trusted, GPs know about you, colleagues know about you, and patients know about you through the other patients you've treated, you don't need Instagram or TikTok or anything else.
So patients shouldn't choose their breast implant surgeon from influencers?
No, there were no influencers half a generation ago. You got to ask, I think, you know, what's their motivation as an influencer promoting a particular surgeon? Are they being paid? Have they had free surgery? Do they actually know that the surgeon's good or not? Have they actually had surgery with this person? I mean, do you know what I mean? Like there's no truth behind that. Whereas if I've operated on someone's sister or mother and they go, actually, you did a good job, there's no social media or anything. It's just a conversation, you know? Or if they go to their GP and say, oh, yeah, Mr. Davies, okay, you know, maybe you should go and see him, you know, that's okay, right? It comes from a trusted source of information. It's not, the motivation there is to be truthful and say, okay, if you want this done, I've had 5 patients that have seen this doctor, he's done a good job or she's done a good job. You know, I endorse that specialist, and that's powerful.
Thank you so much.
My pleasure.
Is there anything that you haven't had a chance to say maybe about the breast implant check clinic or anything else that you haven't had a chance to say yet?
No. Look, I think to me it's been a really interesting conversation. I always like talking to the two of you because whilst, you know, we have a lot of exchange of ideas and thoughts, I actually always learn a lot myself. So this conversation's given me a few little ideas that I'm going to take home and unpack and work on. So thank you.
Anand, what is the dark side of the cosmetic surgery industry to you?
To me, I think the dark side of this industry is the commercial driver. It's there. You can't ignore it. And I think when that becomes the prime directive, that's when I think we're into a very dark place.
One of the most common things we experience when seeing patients be botched is they're met with commentary of, well, you were so vain to get cosmetic surgery to start with. Mm-hmm. You deserve what you got. What do you say to that?
It goes to the heart of a lot of people feeling guilty and ashamed, right? So when things don't go well, they blame themselves. It's not helpful for other people to say those things because it only reinforces their own feelings of inadequacy. I think if someone is truly vulnerable and then is even more vulnerable as a result of a poor outcome, then what we want to do is support them and not blame them, So I don't think that's very helpful at all.
What are 3 tips that you would give to other cosmetic surgery providers?
Number 1, before you open your doors and start seeing patients, make sure you've got the appropriate skills and training. Number 1, right? Don't do things you're not trained for, please. Number 2, look at your own internal motives. Why are you in this industry? What do you want? Yeah. What does your practice want? What are your underlying motives? And 3, just make sure that your values and ethics are in line with, the majority of the population. I think if people spend a bit of time on that internal reflection before they open their doors into cosmetic practice, that would go a long way.
What are 3 tips you would give to cosmetic surgery patients?
Well, number 1, don't sign up for surgery within a week of seeing your surgeon. Like, that's a worry, I think this is elective cosmetic surgery, different for some complications. But if the time frame between you seeing your doctor and the surgery is like a matter of days or weeks, that's an alarm bell. So don't go elsewhere. I would, and now there's a lot of information in terms of credentialing and training. So once again, do your homework and make sure that the doctor you're seeing is adequately trained, certified, specialist, has the skills and is able to deliver, what they say they're going to deliver. Number 3 is, particularly with breast implants, as a patient, I would want to know what sort of surveillance program was being offered. So I'm having surgery with you today. What's going to happen after that? Do I come back and see you every year or not? Why not? So there's got to be something in place for the life of that implant, however long that implant's going to be in the patient and beyond.
In the context of a specialist plastic surgeon, do you have a message for young women who might be having body image issues and are considering breast implants?
Look, I think we put enough pressure on young women in this society today, right? So it's not for me to advise them, but I think just to be mindful that some of the thoughts that you have, particularly in terms of cosmetic surgery, are not coming from yourself. They're coming from an external push. And so once again, just being mindful of all the various forces that are trying to make you feel inadequate or vulnerable or feel like you need some of this. I guess the one thing I would say is, if you're thinking about cosmetic surgery, just remember it's not essential. You don't need cosmetic surgery. So I think if you're going with that thought, this is not something you need, then you've got to really decide if you want to go ahead with it, well, why? And I think that sort of pause and reflection would be good.
Thank you so much, Professor Anand Deva, for your time today. I hope that our listeners got a lot out of it, especially those who are considering breast implants.
I hope so too. Thank you again for your time and the opportunity.
It is important to be properly informed when getting breast implants and not rely on curated and glamourised social media feeds. If you know someone who has or is considering getting breast implants, please send them this episode. Professor Anand Deva's insights are valuable and go a long way in further educating patients. Do remember, though, that nothing in this episode constitutes as medical advice, and always consult with a properly qualified surgeon before going ahead with any surgery. Don't forget, you can follow us on Instagram and TikTok at operation.redress for more content, and you can follow along with us as we explore the dark themes of the cosmetic surgery industry.